Good evening, everybody. It's a great pleasure to see you all here attending our webinar. First of all, my name is Konstantin Kastura. I am a prosthodontist. I've been practicing in Kiev, in Ukraine, in a big dental clinic. And actually, today my practice is limited to restorative dentistry. Personally, I don't place implants, but I do really a lot of prosthetics over the implants, and actually that's the reason why I was suggested to talk about the type of retention of the implant prosthetics. Today we are going to discuss which type the cement or screw retained from the point of contemporary dentistry is more reliable, is more predictable, and what actually contemporary literature says about that, and how in reality in our everyday practice should we choose whether one type of treatment or other will be the better for our patients. So every single lecture that I make begins from this slide. And the reason is very, very simple. My idea is to remind you that we work with living persons. As a dentist, as a doctors, we tend to imagine our patients as machines. We sometimes forget how complex this system is. And we should remember that we work with living patient and there are some laws in our organism, and actually these laws are physiology, and this physiology is really strict. We should follow that to do our best for our patients. And for today, the implant-supported reconstructions are well-established option treatment for our patients. And in our clinic, they have evolved to a standard of care for our patients. We actually do more through year and year. We do more and more implant crowns, single implant crowns, and the bridge prosthetics have been less and less popular as we tend to do the best for our patients. And as the implant therapy evolves and becomes the standard of care, the population seeks the alternatives to conventional fixed puncture dentures and complete dentures for the treatment of edentulous areas in the aesthetic zone or in the posterior region. The success will be dependent upon more than simply an osseointegration. Historically, the actual modern dentistry, implant dentistry, begins from the middle of the last century when professors Paringor Brannemark and Andrew Schroeder suggested the osseointegration concept. That is the point zero for us. And since the middle of 60s till 80s, the Brannemark implant system was the most popular, and actually the restorations were attached to implants and implant abutments with screws. So the implant mechanics were challenging. They were very complex. It was hard for dentists to understand how that works, especially because there were not really a lot of programs where people studied about that. And in the late 80s, the ITI implants, they did a revolution in restorative dentistry, in implant restorative dentistry. This system changed the whole dentistry for many years, actually by just simply modifying abutments so they could be treated like a tooth and actually prepared like a crown, like a simple crown. And that made it a lot easier for the dentists that have been years and years taught how to cement the crowns. And actually, before that, implants were used, originally they were used for completely edentulous patients. The whole idea of Professor Ingrid Brannemark was not to use complete dentures at all. He suggested that that's a worst way to treat people. So the ITI implants allowed us to make very small regions, make single implant crowns, small fixed partial dentures. And actually the system allowed for snap-on impression cuppings and for final restorations simply to be cemented in place. Soon that was followed by 0-1 system and implant restorative dentistry slowly became routinized. Cemented restorations replaced screw-retained restorations as the method of choice for final restorations. And that was the way how plenty of patients were treated. Some dentists were still doing screw-retained restorations, but more and more the cementable options were more and more popular as they were a lot easier. And we will talk more about that later. And in 2009, Wilson described the retained cement in peri-implant mucositis and peri-implantitis. He actually found that a long time after the crowns were cemented, the cement remnants are still present in a lot of implant cases. And he found that even after 9 years post-cementation, it can cause some problems. And actually, the 2000s and contemporary implant dentistry has been focusing on the problem of peri-implantitis. And the most common reason for the peri-implantitis is the cement. And actually, we see that historically studies of implant biomechanics have been focused on the screw-retained restorations as they are more complex and nevertheless the cement-retained designs have achieved broad use despite the limited scientific evaluation. So the reason why people started to use cement-retained designs were simply the simplification of procedure. Everybody tried to do the less constructive paths. And for today, Professor Daniel Boozer says, it's direct citation, since the days of the founding fathers, the choice between predominantly screw-retained or cement-retained prosthetic restoration has been a matter of debate. So as 20 years ago, so and today, there are a lot of discussion about whether screw-retained or cement-retained are the best, what to use, what do we have complications. And actually, contemporary literature is full of information about that. There are plenty of systematic reviews on whether it is good or it is bad. And actually, we see that they're pretty much the same. Independently, they were done 15 years ago or they are very fresh and from the last year. So first of all, are there really a difference between the screw-retained prosthetics and the cement-retained? Actually, that is the only one question that usually patients do not talk about. I've had only one patient that asked me to do only screw-retained restoration. The reason for that was she had a lot of implants with external hexagon done years before, and she had terrible headache about about the rotation of screw when it just fell away, and every time she had this problem, she was needed to redo her prosthetics. So her main concern was it to be repeatable, but generally patients do not think about that, and they do not ask you to do whether this or other type of treatment, which we can say about the other possibilities. They often choose ceramic or metal ceramic types of restoration. They choose material, they choose type of what they want, they choose even the quantity, and sometimes some patients even ask for certain implants to be placed, depending on their experience or the information they read about on the internet. There are really plenty of ways they know about that. So the screw-retained restorations. First of all, predictable retrievability. It's very easy in case of some problems, some events undergoing, to unscrew the crown, check everything, and screw it back. Actually, it's one of the main reasons why 100% of temporary restorations in our dental practice are screw retained. And to say truly, it's much easier. We feel less headache when we perform screw retained reconstructions. And I will show you actually later why. Second part is that it requires a minimal amount of interocclusal space, as minimal as 4 millimeters. We have a lot of patients patients with wrong dentition. The reason, I guess, is the whole stress which they have in their daily life. And the reason why we don't use cement retained crowns in such situations is very simple. They have often cementation problems. The less interocclusal space we have, the less retentive forces are applied to that. And actually, the screw retention completely ruins this problem. Next thing, they're easy to remove for hygiene maintenance, repairs, and surgical interventions. Unfortunately, we do have periodontal patients. They have peri-implant disease, mucositis, and sometimes we need to do additive surgery. Sometimes we need to perform some kind of repairs, and screw retained restorations makes this a lot easier. It decreases the stress of our patients, our stress, and especially for the patients with complete dentures over the implants, the hygiene maintenance for them are a lot easier. The reasons why screw retained constructions are not that good. First of all, it requires prosthetically driven implant placement. Every single implantologist will tell you that it's much harder to find the place to place an implant for the screw retention hole to have the right access. And actually, that's the reason why a lot of implants, contemporary in Ukraine, I'm talking about the Ukrainian statistics, in the frontal region are made cement retained. It's often, there are often not that much tissues, hard tissues to place the implant in a correct position. So it usually takes a lot of effort from surgeon, from the implantologist, and from the prosthodontist to see how should it be done for us to make the screw retained crown. The second part is that manufacturing process is more technically sensitive and more demanding compared to cement retained crowns. It has become a lot easier since we have a lot of CAD/CAM designs, CAD/CAM options, but still a lot of dental technicians don't love to do screw retained crowns, especially over the implants with conical connection. The reason is quite simple. With conical connection, when we screw the implant harder, the level of the occlusal plane goes down. So sometimes we've met that problems 10, 15 years ago when we started to use the conical connection in our dental practice. We've noticed that some crowns were positioned infraocclusally. They do not reach the antagonists. And actually, it's a lot easier to check up, it's a lot easier to do, and it's also detailed more understandable for us how to make cement retained crowns. What about cement retained? They are not as technically demanding as the screw retained. We've been taught that in dental schools and universities how to cement crown, how to prepare abutments, what to do, what kind of cement to use, how to check up the fit. They're also very easily to make a passive fit restorations, especially when we are doing fixed partial dentures on implants. We know for today that that's hard to perform with conical connection. Once again, that's a big question for our implantologists, how to place implants parallel to make the passivity of fit. And actually with cement retained crowns, it's not a problem at all. We just choose the standard abutments, what do we need, or we make the individual abutments, and we simply cement crowns on them. It's a lot easier. Second part, they are less cost intensive to procedure. to produce. Actually, that was right in 2000, 2005. For today, for example, in Ukraine, it costs almost the same for us to do the screw retained or the cement retained things, to CAD/CAM designs, things to intraoral, extraoral scanners. Everything becomes much easier day by day. The third thing I want to show you is actually the possibility of implant position discrepancies compensation. Often implants are placed where the bone is. Actually, that was called the implantology, the surgically driven implantology, when surgeon just places the implant where he is able to. And often in such situations, the screw accessing hole is on the vestibular or on the palatal side, where on the posterior teeth, for example, where it shouldn't be due to the aesthetic reasons. So in such cases, we have only one option to make cement retained crown. The fifth point is prosthetics. It's discussable. Actually, Within says that, but it's discussable. It's a lot easier to make a single anterior crown with cementable on an implant, just due to the reason we can few times try in it, we can check the color, we can change it if we want, and in the way if we glued to the titanium base, it's a lot harder. And it's a lot easier to control occlusion, especially with conical connections, especially in patients with some occlusal disease. The main reasons why we don't use the cement, why we try not to do the cement retained crowns, there are difficulty of removing excess cement. I will show the Linkevich's findings. To say briefly, we are not able to remove completely cement in any way, independently of how experienced we are. They are much more biological. There are much more biological complications in the cement retained groups, and actually whole plenty of systematic reviews we've been watching. They all say the same. The pre-implant diseases have a strong accordance to the cement remnants. And the last point, they are harder to retrieve. In terms of any kind of complication, do we have do we have the screw loosened, or we have some kind of chippements? We need to cut off the whole reconstruction, and often that's the only way to do that. So when we're talking about complications, the total event rate is always higher with cemented reconstructions. What does that mean? That there are more problems, we face them more often with cemented reconstructions. If we're talking about fractures and chippings of ceramics, they are really high with screw-retained reconstructions. Why? Because we have a screw retention hole, and especially with narrow crowns, for example, premolars, there are less reinforcement for the ceramic, and so we have the chips. On the left photo, you see it's the lower second molar. Distally, after 2 years of function, we have achievement, and actually, as for me, I don't see the problem. We just have some compensation from our occlusal sensory system. The losing of abutment is really a lot higher with cement retained group, and that's actually the biggest problem. When the screw is loosened, when the abutment is loosened, we need to somehow to screw it down to make it, to fix that in place once again. And as you see on the right photo, often we need just to cut the crown as far as there are no other options. We do not have direct access to the implant, and often that ends up in changing the whole restoration. So, direct citation. The total event rate for biological complications was significantly higher with cemented compared to screw-retained reconstructions. Presence of fistula separation appears statistically significantly more often with the cemented reconstructions. And actually, we've seen that a lot. Some patients came to us from other dental clinics, and we see the slides like on the third where we have fistulas, we make tracing röntgen, we make tracing X-ray, and we notice that it goes just directly to the implant. So let me show you the clinical case with cemented crown. On the first slide, we see the patient with temporary screw-retained crown, and we see that access hole is just on the middle of incisal edge. Our implantologist tried their best to make it more palatable, but unfortunately, we have what do we have. And in case if we will do the screw-retained crown, it will be disaster for the patient. So, what do we see next? We see the emergence profile we have modified, and we actually see the custom zirconia abutment on the place. After we tighten the screw, we tighten that with 35 newtons with dynamometric range. We simply, like with natural teeth, can cement the crown. And the main thing we need to match, and thank God we have a microscope in our daily practice, the precision of abutment crown interface. It's the main thing we should notice, the main thing we should have. And on this slide you see it's pretty much perfect. We don't see the finish line. That might be, sorry, that might be a little hard for our dental technicians, but if everything is done properly, that's the picture what we should see when we try in our crown with definitive abutment. So on the next slide, we see the final crown cemented, and I was a little bit disappointed because we chose the wrong chroma. Actually, I was ready to redo this crown when we were trying it in, but somehow the patient liked how it looked like. I don't know why, but she was pretty happy with this hyperchromatic layer on the cervical part. And the second thing I see is we have overcompressed the distal papilla. That's the one thing we have not mentioned while we were cementing. And I've seen this patient 2 years after. What do we see on this picture? We see the swelling gingiva. Actually, the main thing we do correctly, as you see on this slide, we placed the margin, the shoulder, equigingivally. So that was really easier to remove cement. I will also show you at the end few techniques how to make it more predictable, and we use them. So I was not afraid that we will see cement, especially because this is frontal central incisor, and that was really easily to clean that everything out, especially because we have the equigingival margin. But still, she has inflammation, and this inflammation she has only after only 8 weeks after professional hygiene. And I've made the photo for her. Actually, we made an X-ray, and on X-ray everything is perfect. We don't see the cement remnants. We don't see any problems, any complications. The marginal bone loss is almost zero for this case, which seems to be perfect for us. But still, she has inflammation. The reason of this inflammation is actually her personal hygiene. And bad hygiene destroys implants in any way, independently was that the screw retained, whether that is a screw retained or cement retained, doesn't matter. Bad hygiene destroys implants. Once again, I've done this photo. I always do such photos for our patients when they have some problems with hygiene. I show them and ask a simple question. Does that look naturally to you? Does that look healthy to you? She was very disappointed. She thought that that's just how her gingiva should look like, but since then we see small improvements in her hygiene. Without her hygiene, everything will be simply destroyed, everything will be lost. So, moving forward, the retrievability. As I've already mentioned, in cases with screw-retained crowns on the left, it's easy to change anything we want. If we have chipping, we can unscrew the crown, correct that, and screw it back. If we think that profile is not ideal, we can unscrew that, correct, and screw it back. If we have some problems with gingiva and we need to make a surgical intervention there, it's a lot easier for a surgeon to make that without crown, because he has 360 degrees view. In cases where we have cemented crowns, we need to find the place where actually the abutment is placed, and only after that we can unscrew. And as I already mentioned, that often ends up in destroying the whole crown. For example, as you see with central incisor, there are possibly no way for us to put that restoration back in place. In such situations, we usually cut down the crown, make a temporary, and we wait time. We look for the reason why we had some problems. Often it's the screw loosening, the abutment loosening when the crown is moving forward and backward. And the only way often is just to destroy the crown and to make a new one. And that always is disappointing for us, for our patients, for our dental technician when he or she needs to do it once again. So for daily practice, we try to avoid this type of crowns. So the hygiene maintenance. On this slide, you see a simple PMMA temporary bridge. Actually, it was done instead of complete denture. It's completely edentulous patient. And you see how our patient maintained the hygiene. It was in place only for 3.5 months, so not that long. And if we make cement retained reconstruction, final cement retained reconstruction, we wouldn't be able to take it off and clean that, as we can easily do in such cases with multi-units. And often our patients with complete fixed partial dentures, with screw-retained complete, we see them at least once a year, and once a year we unscrew them, we clean everything there, we look for in which places is it harder for our patients to clean. We year by year teach them how they should maintain the hygiene. And for cement reconstruction, it's really hard. We often see simply how patients are not able to clean, and we are not able to help them with that. So the next case I want to show you, it's actually a patient that came for us with a problem. What do you see on the picture is the actual fit of crown to zirconia abutment. That was actually how it looked like intraorally. As you understand, there was a lot of cement. It was everywhere. It was beneath the crown, it was beneath the abutment, it was all around in the soft tissues, everything was inflamed, and the main concern of the patient was the pain that she felt and the presence of fistula. And on this slide, actually you see the presence of fistula. What did we do? We tried to take off the crown. Fortunately, we could do that with aid of some other instruments, and actually we unscrewed the abutment. The surgeon did a surgical intervention. He cleaned the cement remnants, and after that he simply filled it with healing abutment. After the healing abutment, we made a new temporary crown, and as you see, right after debridement and screw-retained temp crown on the implant, the fistula has been closed. So the only concern, the only issue with this implant, the only issue why we had a huge inflammation, a huge discomfort for the patient, and the only reason this patient left his restorative dentist was the inability of doctor to clean out the cement with the finish line 1.5 millimeter below the gingival level. And we will see in the on the researchers why is it hard to do. So let's move on. The platform switching. Actually, the platform switching has been advocated as a method to reduce marginal bone loss by redirecting the effect of the implant connection biofilm more vertically than horizontally. So the biological width was formatted not vertically but horizontally. So we've seen a lot of researches, for example, Lazaro, where platform switching changed a lot. It was actually a paradigm shift 10 years ago, and for today, almost every type of conical implant has the platform switching options. A concern of platform switching is the creation of additional horizontal undercut, which further complicates the cement removal. And we see on this slide, the courtesy of John Perry, we see how hard it is to remove cement from beneath this position of a crown. And the great book, The Cementation in Dental Implantology, actually shows that we often do not have the right access to remove the cement from this undercut. It's not hard to do, it's impossible to do. Often that's simply impossible to do. We must remember that, we must understand that, and it's okay if we can see the cement on an X-ray. But sometimes we use the cements that are not enough radiopaque, and sometimes the cement remnants are on the buccal, lingual, or palatal sides where we just simply cannot see them on an X-rays. As early as 1997, Agar and colleagues concluded in an in vitro study that the process of removing excess cement from subgingival margins after cementation of restoration to the implant abutment can lead to the scratching of abutment. And actually, that's not the main concern. They also noticed that the cement removal can be incomplete. And in fact, it's almost always incomplete. Another investigation showed that the deeper the margin, the greater the amount of undetected cement, with the greatest amount of cement found in the groups where the margins were placed 2 and 3 millimeters submucosally. That was often done because some stock abutments, some systems don't have stock abutments with different gingival level. And as far as you know, for example, the Bio3 or Orthodent, they have stock abutments with different shoulder levels, which makes a lot easier to choose the correct abutment independently of how deep the implant is placed and how much of the soft tissues are there. And that's really important. So the recent investigation found that about 81% of the implants restored with cement-retained single crowns with clinically and radiological signs of periimplantitis had extracoronal residual cement presented. Therefore, this study concluded that residual cement might act as one of the predisposing factors for the periimplantitis development. Implants with cement remnants in patients with history of periodontitis may be even more likely to develop compared with implants in patients without the history of some periodontal disease. So, as you know, without me, the periodontitis, chronic periodontitis, is a factor of risk in current implantology, and that's topic number 1 in today's conferences. So, in a study reporting on the clinical and radiographic reexamination after 9 years of almost 600 patients who had all received implant therapy, higher odds ratios, higher problems were developing of periodontitis were identified for implants installed with crown restoration margins positioned more than less than 1.5 millimeter from the crestal bone at the baseline and more than 2 millimeters deeper than mucosal level. And actually, we know that success rate of these prosthetics does not seem to be affected by the type of retention. That's the next thing we should also mention. The research of 2017, in this research, the authors tried to see whether how hard is it to remove the cement, dependingly on how our abutment looks like. What did they did? They made models with a rigid gingiva mask. They made an abutment with convex and concave profiles, and actually they asked the experienced clinicians to cement crown and the clean remnants. After that was performed, they took away the gingiva mask and they were examining. What have they noticed? They have noticed that a lot more cement were left in the group with concave abutments. And in that cases, two things that we need to consider. First, there were no real patients, which actually don't like when we try to scratch off the cement from beneath the abutments. So the professionals, so the doctors did that as long as they needed to. And the second thing, the gingival mask is a lot more rigid than usually mucosa is. So I bet that in clinical situations, in our everyday practice, the results will be even more dramatic. So residual subgingival cement seems to be strongly associated with peri-implant mucositis, which is a risk factor for increased probing depth, crestal bone loss, and peri-implantitis. Zinc oxide eugenol cements should be preferred to resin cements, especially in the patients with a history of periodontitis. Actually, we will talk a little more about cements a bit after. Now we need to understand the mechanics of the screw retention, how that works. First of all, screws tighten up from 50 to 75% of yield strength. That's the way how performing the clamping force. The torque applied, tensile force also applied to the clamping force. And also the accurate fit of our components, of our stock abutments, for example, of our CAD/CAM abutments, they do not stress the screw. And actually, if you want to know more about how that looks like, there are plenty of literature. For example, the picture I've posted on the left is very completely described in the article by Gebel and Gajar, the cement retained versus screw retained implant restorations achieving optimal occlusal and aesthetic in implant dentistry. It is really interesting, but just in cases if you want to know the mechanics. Next thing, the abutment requirements. They are very simple, pretty much the same as they were described in Schillenberg's prosthodontics. First of all, the taper. Machined abutments always have exact 6 degrees taper. The more taper we have, the less retention we have. If we have a taper less than 6 degrees, for example 4 or 5 degrees, we will have some cementation problems because the cement won't flow. The surface area, increasing in the surface area increases the retention. The longer the abutment is, the better the cement works. The same as in regular prosthodontic cases. The surface finish line, the surface finish. Raw axial walls provide increased machined mechanical retention. Once again, the more retention when we, for example, sandblast our abutments. And that is, once again, is pretty much the same as with natural teeth. That's actually the reason why cementable reconstruction became more popular in 1980s. So the cement selecting, what I want to show you first of all is the study. The prosthodontic residency directors were in 2008 were just asked what cement usually they use for conventional fixed restorations and for the implant restorations. And what do we see? That usually the resin modified glass ionomer was used, sometimes even polycarboxylate. And here I want to stop because the polycarboxylate is the worst way, as we know today, it is the worst way to cement the implants. Why? Because the polycarboxylate cement has a lot of fluor in it as a part of it. And unfortunately, with today's titanium surface, it can interact and cause corrosion. If we don't want corrosion, we shouldn't use the polycarboxylate cements. And as you see, the thing was pretty much the same in 2013. And about the zinc oxide eugenol, why is it better? First of all, it's semi-soluble. Even if the cement will run away, and even if it will be in the soft tissues, there is some possibility that it will simply disappear from our soft tissues. The second thing, it doesn't cause the inflammation. And the main event why, for example, resin modified glass ionomer is not that good for cementing the grounds is the ability of microbes to grow on the glass ionomers. There was a study in the literature when they simply made discs with setup cement, and they made the cultures over that. What did they notice? They noticed that there were actually no cultures, there were no microbes on zinc oxide eugenol cements. So they are antimicrobial. We all know that. And as we see through the literature reviews, plenty literature reviews, the implants with cemented reconstructions, cemented on zinc oxide eugenol, are usually less spended to periimplantitis. So we see the periimplantitis not that often in cases where we use zinc oxide eugenol cement. So in our daily practice, soy is one of the methods of choose for implant restoration, for cemented implant restorations. In this case, I want to show you how Bio3 BioLine abutments can be used. Actually, the whole idea of BioLine is the natural emergence profile, and they are every part of BioLine. It is abutment, it is healing abutment, and the conventional abutment. They have the same emergence profile from the very beginning to the end. And the next important thing is that the gingival margin level is scalloped. It is scalloped on the way it is usually presented intraorally. So it's a lot easier to remove cement in such cases. And actually, we've done a cemented metal ceramic crown on the BioLine abutment. It was really straightforward case, and certainly it's a lot easier to do than with conventional stock abutments, which are usually hard to create this scalloped gingival level from all sides. BioLine is a lot easier in these cases. So what type of abutment modifications can we do to improve our retention, to improve our prognosis? First of all, air abrasion. As I've already mentioned, it increases the surface energy. The second part are the grooves on abutment. As you see, we've done on this premolar. The vertical grooves allow easier cement flow. So once again, we need to understand that cements are non-Newtonian fluids. We'll talk about that more. And grooves make that a lot easier for cement to flow away and not to contract, not to make stresses on our occlusal part of our crown. The third thing, closing or leaving abutment screw hole open. Actually, that reduces the amount of cement excess. If we leave it a little more open, it makes a little bit easier for us to cement the crown down. The internal venting. Sometimes we do small holes in the crown for the reason to change the flow of cement. That might be beneficial in cases if we will have bubble traps in the cement. Abutment finish line. Actually, that's the study by Thomas Linkevičius. We have the link on it before. What did they done? They done plenty of abutments, and they asked the doctors to cement the crowns over them, to clean the remnants with gingival masks, and They just were looking through how that looks like. Their conclusions were the deeper the margin, the harder to clean. If we have more than 1.5 of 2 millimeters below gingiva, it's almost impossible to clean the whole cement. The second thing, the knife edge finish line is the most unpredictable, and it's some controversial in today's literature. On the other hand, we have bio-PT, where even on implant abutments, we perform knife edge preparation, and we can cement crown. And by modifying the crown, we can modify the gingiva. I wouldn't recommend to use that unless you are pretty, unless you are 100% sure that you can clean all the cement. Especially, I will not recommend it to do if you have the marginal level below 1.5 millimeter below the gingiva. And the third part, shoulder should follow the gingiva line. If we have the shoulder on the wall level, we will have problems on the interproximal area. Why? Because the interproximal papillas, they usually cover some parts of cement, and we don't have direct access. We often don't have the direct access, and that's often is an issue for future periodontitis, periimplantitis. I'm sorry. How to minimize the cement remnants? There are three. Vidavi describes three possible ways that are being used in all over the world how to cement the crowns. One group of the dentists usually fill completely the crown, as they do with natural abutments with teeth, and after that they cement the crown. The second group uses brush to applicate, and in such cases we see the brush strokes. And the third group of dentists usually perform only rim application. They push the cement only on the shoulder level and hope that that will cover all the crown. To say truly, we've done a lot like group 3 until we've noticed the Vidavi research. They looked a lot, they made a lot of models, they were just noticing how the cement flows. And actually they've noticed that most predictable is the brush application, because in the first group there is 99% reason we won't push the crown to the end. It will, just due to the plenty of cement in the occlusal region, the crown will not be completely seated, unfortunately. In the third group, fortunately, there are 90% that we won't have any micron of the cement in the occlusal region, which is actually not good, because it can cause the cementation of the crown. And the second group are actually more predictable from these three groups. What they also mentioned, almost all cements in dentistry are non-Newtonian fluids, so they flow differently than water. They do not fall away, and actually that explains a lot why often we cannot seat completely the crown. Independently, on the try-in, we've seen that we have a perfect fit. The cement in the occlusal part of crown resists completely seating and causes stress. So personal Vidavi suggestion is never fill the occlusal part of the crown with cement. Usually the best way to apply that with a brush on the middle part of the crown. The more force we apply to crown during the seating, the more chance to damage surrounding soft tissues. There is a high possibility, if we hurry up when we're cementing, simply to damage the tissues, and actually that 99% will cause the periimplantitis. Also, they've noticed that slower the seating, the more homogeneously cement flows. So from all of this, what we need to know, what we need to understand, actually we need only 3% of the surface, only 3% of the cement than we usually use. We need to brush it very easily. We do not need to have a lot of cement. We need to place slowly. We need not to push the crown while sitting too much, because every think every part of the thing we will do wrong will cause, actually can cause the perimplantitis. It can cause the cement remnants beneath our abutment, and in 5 to 9 years, according to the literature, there's a high possibility we will have periimplantitis. So there are a few techniques that are actually making it a lot easier to remove the cement. The first of all is the rubber dam technique. It can be used on a segment, on a one tooth, or some dentists, as I know, touch the clamp on the neighboring tooth, and they're actually making the complete isolation. In such cases, it's better to use the heavier rubber dam because it can compress the gingiva, and with the rubber dam on, we can visually better see the cement, and there is slightly bigger possibility for the cement not to flow beneath the rubber dam. Unfortunately, it flows beneath, but not in that quantity as without the rubber dam. Once again, there was a study when, usually how we did that 10 years ago, we just took a cord, placed that intercircularly near the implant, cemented, and just took off the cord. Unfortunately, often this cord does nothing. Once again, according to literature, according to big researchers, the method with rubber dam makes it a little more predictable. But personally, for me, the method of choice is the silicone dye technique. What do we do? First of all, we take the crown before cementing, and we make some kind of spacer. Like dental technicians, they place the spacer over the die. We just use PTFE, Teflon. We insert it inside the crown, adapt that, and actually it works as a small spacer for us. It usually gives us nearly 50 microns of space for cement to flow. For contemporary cements, we need at least 25 microns for cement to be homogeneously all around the preparation. So after that, we use kind of bite registration material that fast sets. In these cases, that was blue mousse. Usually we use futar for that. That's the main idea is to use very rigid material. And we have kind of cupping of our abutment. After that, we place abutment intraorally. We completely screw it, and we can. And we first with cement. We fill the crown with cement. After that, we cement our crown on a silicone die, so all the cement remnants flow away. And after that, only after that, we seat the crown on an abutment. In such cases, we usually have nearly 0 cement remnants all around the crown. So for today, it's the most predictable way, and I know plenty of dentists using that day by day. It was practice changing for me, and I'm happy I have an ability to share that with you. So take home message. First of all, the proper treatment planning is mandatory. As already mentioned, the implant position should be prosthetically driven. In such cases, we can make screw-in crowns and make our lives and lives of our patient less stressful. The second part, the success rate of these prosthetics does not seem to be affected by the type of restoration. The main problem with contemporary implants is the periimplantitis. The main cause of periimplantitis, unfortunately, is cement, but not the type of prosthetics, whether it is single crown or fixed partial denture or veneer on an individual abutment. That doesn't matter. The third, both retention types have their advantages and disadvantages. Same as for the screw retained and same for the cement retained. Cement retained reconstructions suggested where easier control of occlusion is needed. In the patients with hard occlusal disease, when we need to be very, very, very precise we sometimes use the cement retained reconstructions, especially since we developed the silicone dye technique for us. Once again, it becomes more and more predictable. Fifth, the major problem of cement retained prosthetics is cement control. We've talked about that really a lot. There are some techniques, but still literature says that the cement retained reconstructions are in group of risk. And last, screw retained prosthetics showed higher incidence of chipping. We should be ready for that just because we don't have enough support for the ceramic in such cases. But for a lot of our patients, it's okay to have risk of chipping instead of crown removing in case of abutment loosening, which sometimes unfortunately happens. Also, Whitneben showed a very simple scheme on how to go, whether we should screw or cement retain our crowns. First of all, we need to choose is this teeth anterior or posterior? If it is anterior, is it bone level implant or tissue level implant? 99% of implants in our today practice are bone level. With bone level implants, we always can do a screw retained provisional. It's really easy to mask the screw retention hole with composite. And if the implant prosthetic in ideal position, we easily can use screw retained. If the implant prosthetic is malpositioned, we need to use the cementable reconstruction. But the only thing we should consider, the crown margins not to be too deep. In case of posterior implants, if we have inadequate interocclusal space, less than 4 millimeters, not less than, for at least 4 millimeters, we should use the screw retained reconstruction. The cement retained will unfortunately de-cement. If we see the posterior reconstructions and the implant is ideal position, 100% it is screw retained prosthetics. In case of intact occlusal surface desired for narrower crowns or due to some occlusal events, or implant is malpositioned, we can and we should use the cement retained crowns. Actually, keep calm and use science. It will make a lot easier your practice. Thank you a lot for your attention. We now will make a pause. Okay, we will make a little pause for 1 minute to check out questions, and we will be back in a minute. So we are back, and let's talk about the questions you left. First question about how the conical connection affecting the occlusion. Not the conical connection by itself, but the thing that we dental technicians never, when they're manufacturing the crowns, they are never screwing it with the torque that we need on the final restoration due to the screw can be damaged while this will be repeated a few times. So they do crowns in some kind of, my dental technicians, I ask them to make them a little hyperocclusionally, so make them a little bit in superocclusion. So when we push the torque range to 35 newtons, and with conical connection, we don't have that stop point like with external connection, for example, or hexagon connection. And when we're screwing the implant down, the crown actually goes lower and lower and lower and lower. And sometimes we've met with this problem, is 10 years ago last time, when we screwed the crown down, and we've noticed that the crown is actually not in the occlusion. And we were disappointed because we had the glued in the T-base crown. We just needed to redo that. Next question. Yes, I was saying that more tightening of screw actually may affect occlusion. It will cause not the occlusion. It will affect the occlusal plane of our prosthesis. The next question is about the zinc oxide. Is about the cements. Is it strong enough to last for a long time? As the abutments that we use are very retentive, they have 6 degrees, they have almost parallel walls, they are long enough, and we can modify them. Usually, zinc oxide eugenol is enough. In any way, I would rather have the crown decemented, my crown or crown of my patient decemented, instead of seeing the preimplantitis, instead of seeing some microbes on the cement. According to literature, it's recommended to use zinc oxide eugenol over resin modified glass ionomer, just due to the reason, just due to the purpose not to have more microbes in our transmucosal profile. And actually, according to those researchers, the zinc oxide eugenol, whether it is extempore or it is being manufactured, they all work good enough. Can you repeat about the abutment modifications? Yes, I have opened the slide with the implant modification, and actually there are 4 points that I mentioned. First of all, air abrasion. It increases the surface energy. Then groove on the abutment. It actually allows easier cement flow. The closing or leaving the screw hole open depending on how big the taper is. For example, sometimes we are doing cement retained fixed partial dentures on implants, and the placement of implant tells us to do a little bigger taper. In such cases, I fill the screw hole to the maximal level for the cement to cover more and more my abutment. In case of single crowns, almost never I leave the hole completely closed. It's a little bit open just to compensate the forces when I'm sitting the crown down. And actually the internal venting, it's once again when we have single crowns and when taper of abutment is high and we think that our cement might completely flow out. Sometimes the internal venting helps, but usually we don't do them. It's enough to leave the screw hole a little bit, not completely, but a little bit opened. Next question, the rubber dam technique. The best and easy? For me, not, because I've noticed, I've seen that some cement still, personally, I've done few screw cemented crowns just to check myself how easily can I remove the cement. And I noticed that using the rubber dam, even very heavy Nickton rubber dam, unfortunately the cement flows beneath the rubber dam. And that was very pity, but since we usually use the silicone dye technique, it's become a lot easier for us. So I guess we've answered all the questions. Anyway, I will show the last slide. Here are my contact email, my Facebook account, anytime, any day. If you have any questions on this topic or any other, if I can help you, I would be happy to answer you. So once again, thank you a lot for attention and have a nice day.